Welcome to the show, Healthcare from the Hill. In this show, we discuss medical events and related issues, as well as interview individuals all the way from the patient to the healthcare professional. I'm your host, Dr. Amit Lahav, and I would once again like to dedicate this show to our former host, Mr. Robert Howell, who this show would not have been possible without him. We have an interesting show today. We have our esteemed guest, Dr. Vito Errico, neuroradiologist from Diagnostic Imaging of Milford and Milford Hospital, as well as one of my patients who has had a total hip replacement, Mrs. Gina Foster, who is a registered nurse and a very active individual who will show us that you can have an exciting life after hip replacement. We'll speak both about radiology and what it involves, as well as spinal fractures and treatment, in addition to going to a hip replacement and the life you can enjoy afterwards. Stay with us. We'll be right back. Welcome back to Healthcare from the Hill. We will start today's show with Dr. Vito Errico, neuroradiologist from Diagnostic Imaging of Milford and Milford Hospital. Dr. Errico, thank you very much for being here today.
My pleasure. Thank you. It's an honor for you to invite me here.
Well, we know that radiology, as some people think, is a doctor who sits in a dark room just looking at films and looking at x-rays. But we both know that radiology has a lot more. There's the interventional part of radiology. There's also different films and different type of skills that you have as a radiologist. And with today's technology, really everything from MRI to more invasive procedures, the radiologist really takes a front seat role in the care of the patient. Tell us a little bit about what type of radiology do you do, what is your specialty, and what is your preference to do?
Well, within radiology, there are different subspecialties. And the one I'm in is neuroradiology. So it combines a lot of neuroanatomy with radiology. In addition, it has some intervention involved, like you alluded to, where you can actually help the patient more than just making a diagnosis. I perform procedures which involve vertebroplasty, which I'll get into, and also epidural steroid injections, which also helps with back pain. So beyond just, like you said, just viewing the images and making diagnosis, we are able to provide treatment for the patient for back pain.
So when you say neuroradiology, just to clarify that, it has to do with the nerve and spinal cord, as well as the bone structure and ligaments of the spine. And if we go to our model here, which is a spine, where your head would be right up here, and this is your entire spine, going from the cervical, which is your neck, to the thoracic, which is your mid-back, to the lumbar area, which is your low back. Entirely, this forms your full spine. And of course, from the bottom part, it connects to the sacrum and then the pelvis. At each level of your spine, these little things that come out right here, those are nerve roots. So your spinal cord goes through the back part of your spine, protected by a bony architecture, and at each level sends out two roots to each side of your body. And each one of those roots forms your peripheral nerves, which help work with function, such as sensation, motor, as well as other type of sympathetic and parasympathetic type of function, sort of what helps you with your digestive system and so forth. So things can happen along your spine. Beside having fractures as well as deformities, you could actually have small compressions over these nerves which tighten around the nerve, as some people refer to as a pinched nerve. And there are treatments that can be done, which is not always surgery, and this is really where Dr. Arrico comes into play. Things like spinal injections, epidural injections, facet injections, those are different type of injections which are done at different locations of the spine. And if I may ask, how do you determine really where you want the injection to be?
Well, that's a good question, because I think as a neuroradiologist, we provide more insight into treatment, because we're able to see landmarks, anatomic landmarks, to guide us as to where to inject. So you put together the patient's clinical history with the films and the MRI. So on an MRI, you're able to see the disc and see where the nerve is being impinged. So with those tools, you're able, and the patient's history, which is very important, where the pain is going to, if it's radiculopathy or just staying locally, you can really direct your treatment with the epidural versus just injecting blindly, which I discourage.
So you can do essentially pain management as a radiologist for an orthopedic or neuro condition, essentially.
Yes, you can. Yes. So to differentiate again, the two things that I perform as a neuroradiologist is epidural steroid injection, which is injecting a steroid into the epidural space, which is the coating of the nerves, versus where there's a compression fracture, you actually put in what they used to call medical cement, which is polymethyl methacrylate, PMMA, which the orthopedic surgeons use often for stabilization. So those are the two things that I do beyond reading films, reading an MRI, and things like that.
So once the patient, let's say, has some pain and some issues and compression or pinched nerves, and they've seen the orthopedist or a neurosurgeon, and they may send the patient back, let's say, to you to say, we'd like this patient to have an epidural injection or a facet injection. You essentially take that history of the patient, what their complaints are, then help you guide it. You generally get an MRI rather than just an X-ray.
Yes, because an X-ray will just show you the bones, really, and that is helpful initially to see if the patient fell and has a compression fracture. So the initial plain X-ray, the traditional X-ray, is just for bone structures. But if there's something beyond that, and there's radiculopathy or there's radiation of pain, and you're thinking it's more of a soft tissue condition like a disc herniation, then you need an MRI.
So all these new studies that are out there, beginning with X-ray, which shows essentially the bony architecture, and can give you insight into possible soft tissue component to that. You can move on to a CAT scan, which is essentially a thinner slice type of X-ray, which gives you a little bit better insight into the bony architecture, all the way to an MRI, which is very good to seeing the soft tissue structures, like the discs, the ligaments, any type of lesions, even things like tumor in the spine, as well as obviously using things like ultrasound, which is used a little bit differently in things like breast, for instance. We have some images. Maybe we can just discuss a little bit of what an X-ray is versus what an MRI is.
Sure.
If we can go to the first image of an X-ray.
Okay, so here is what we call a lateral plain film of the lumbar spine. So basically the rectangular structures are the vertebral bodies, which are right here. So this is taking an X-ray this way, and you're seeing the actual vertebral bodies on the lateral X-ray. So that just shows the bones, the traditional X-ray that shows the bony, because the X-ray penetrates the soft tissue, so you're not able to really see the soft tissues.
So let's go to the model again, actually.
Sure.
So now that X-ray was the lumbar spine. So what do you have there?
So this is a model of the lumbar spine, and the X-ray just showed you what is this projection, which is a lateral projection. So the box-like structures are the vertebral bodies right here, and these are the spinous processes back here. So that's what that showed, and this is actually the sacrum and the part of the pelvis. So that's what the X-ray showed. The X-ray can't penetrate the bones, so it shows as a negative structure on the X-ray.
And if there's a bony deformity, you'd see it on the X-ray.
Yes, correct.
Okay, and then if we can go to an image of an MRI,
Well, first we'll do the CAT scan, and this is the CAT scan is similar to the plain film because it uses X-ray to develop an image. And here it looks very similar to what I showed you in the first place, but this is what's called a sagittal reconstruction of a CAT scan. So the CAT scans are usually obtained in the axial plane, but this representation is actually a what we call a sagittal reformatted image. So it's the computer generates this image to show the bony structures on a CAT scan. So it involves X-ray.
but it gives you better imaging of the bone, really, rather
Yes,
than the
much more
soft tissue.
detailed. Right, more detailed for the bone. A little bit of soft tissue, but not as great for the discs as an MRI would be, which we can show as well.
So why don't we go to an MRI?
Okay, this is an MRI of the spine, so you could see that the ligaments, like Dr. Lahav had alluded to, are better visualized in the back there. Then the white stuff that you see centrally behind the vertebral bodies is what we call cerebral spinal fluid, or CSF. And then you could see the dark little plates in between the vertebral bodies, and those are the discs. This is an older patient, obviously, because the discs are black, so it's lost its fluid content. I brought this image because you could see both the normal vertebral body, which is a nice rectangle, and then you could see some that have lost that shape and become more like concave and biconcave actually, and those show the compression fractures. So, and it also shows the bone marrow as signal. So if there's any loss of signal in the vertebral bodies, it would be manifest as a compression deformity, acute or late.
And a little later on, we're actually going to go a little bit into more detail about fractures and what you do as a radiologist to treat those type of fractures.
Okay.
So the MRI essentially gives you more of disc pathology, so you can look for disc herniations. And if you know the level of the disc herniation, you can target injections specifically at that level to help reduce the swelling around the nerve root, which can, in addition, help you with the pain and make it better that way. Is there a limitation of how many injections you can have for the spine?
Yes, because steroid or cortisone, same thing. Steroid is more the generic medicine. It could be very good. It was a miracle drug that came out in the 60s. When it came out, it was called a miracle drug. But then people started to know with so much use of steroids, it can actually have some detrimental effects. So you have to be careful as to how much you use. So to answer the question is, we allow a patient 3 injections in a 6-month period. And we really don't like to go beyond that because of the possible detrimental effects of steroids. But I haven't seen any. For instance, if you're a diabetic, it can elevate your sugars a bit, but we control that and we look at that. I definitely do diabetics, but I keep an eye on their sugars with the cortisone.
So you take a look at the whole patient.
The whole patient,
essentially,
right.
not just the spine, the medical history,
Exactly.
their symptoms. That's actually very important because
Yes.
the patient just doesn't come in as a spine. There is the whole body connected to that spine.
Exactly.
That's actually very helpful, and it's, I think, a team approach of what you do regarding their, let's say, orthopedist or neurosurgeon or even primary care physician who send that patient to you really for further, more invasive type of treatment that can be done. As a radiologist, do you work just in a private setting, or do you also work in the hospital, or there's some kind of combination of where you do different procedures? Because some are outpatient procedures, and some patients need a little bit more of a little bit more invasive or any sedation for some of these procedures that you do.
Right.
Do you distinguish where the patient goes for